He still has his vegetation, as you can see here. And then a look at the mitral valve shows that there seems to be somewhat an echolucent spot within this protuberance seen on the valve leaflet. There's also multiple jets of mitral regurgitation. I alluded to other issues as well, that you have to, in a normal course of follow-up, it's good to look for aortic stenosis and regurgitation. This person actually had severe regurgitation just because he had an endocarditis damaging the valve. On the 3D images, we went on to look at the aortic valve and then the mitral valve, and it appeared that he had an abscess which had probably drained and led to that echolucent spot that we noticed on the transthoracic echo. And the surgeons actually confirmed that the valve, the bicuspid aortic valve, had been severely damaged by the endocarditis, but also that the mitral valve was fenestrated by the contiguous spread of the infection, despite receiving antibiotics. So this patient underwent aortic valve replacement with a mechanical valve and mitral valve repair with pericardial patch for the multiple fenestrations. We've already heard a wonderful talk about the use of echo for mitral valve prolapse, but I'd like to go on to talk about some of the other congenital heart defects where our decision during pregnancy is influenced by the imaging results. We have known about pregnancy from the hieroglyphs that you just saw from Egypt. The Egyptians, 3,000 years ago, knew about the use of instruments that probably were used to perform a similar procedure to a cesarean delivery today. Here we can see the complete array of the instruments on this hieroglyph. But I will share with you a couple of cases in the interest of time where young women present for preconception counseling. Here is a 26-year-old lady who had a history of atrial septal defect, repair in childhood, and now comes for preconceptional counseling. As you can see on this transthoracic echocardiogram, she has significant mitral regurgitation, and this valve definitely does not look normal. Further evaluation by 3D echocardiogram demonstrated a major cleft. This patient actually had a cleft anterior mitral valve leaflet, which may be associated with a primum ASD, as was in her case, or may occur in isolation. The unfortunate part is we always associate primum atrial septal defect and cleft anterior mitral valve leaflet with Down syndrome, but that's not always true. This was actually a very brilliant school teacher who had this defect, and it is surprising that in childhood she never had the mitral valve leaflet repair. I can understand that now more after listening to Dr. Munkard's talk, that it may not have been diagnosed by the modalities that were available in those days. And briefly, I'll say that it's always important to do a complete study because the defects go with some associated problems, and I see what the mind knows. So it's important to know that if the defect occurred in isolation, that is the isolated cleft mitral valve, the patient may have a VSD, coarctation of aorta, a double outlet right ventricle, or tricuspid atresia. But however, most people have significant mitral regurgitation, which may lead to left atrial enlargement, left ventricular enlargement, and decreased function, and are at risk for endocarditis. My quick question for the audience is, should this woman be asked to go ahead with a pregnancy, or you would discourage her, or you don't know? How many of you agree that she should go ahead with her pregnancy? A raise of hands, please. Okay, very few. Actually, I would say she can, because regurgitant jets are very well tolerated during pregnancy unless she's already presented with heart failure. As we see here, there are several cardiovascular changes that take place during pregnancy. The blood volume, the cardiac output, and the stroke volume increase considerably by the second or third trimester. The heart rate also goes up to meet the demands. However, the SVR is decreased, the PVR is decreased, hence regurgitant lesions are well tolerated. But this cannot be said for obstructive lesions or patients with symptomatic arrhythmia, CHF, stroke, cyanosis, or a poor functional class, or those who have a bad ventricle. Here, I just wanted to also tell you that when we were looking at the parasternal long axis view, you'll see the gooseneck deformity, which goes with is well seen in people who have primum ASDs. Our next case is a 23-year-old asymptomatic lady who presented for preconception counseling. Take a close look at her short axis view. What do you think she has? And that will be my next question. Here you see in the apical two-chamber view, you know this valve is not normal, but what does she have? Does she have a congenital condition or is it acquired? How many of you think it's congenital and how many of you think acquired? Show of hands for congenital. Again, most of you probably think it's acquired. I'm just taking that. Okay, actually there is an acquired condition that can look like this. Some people who've undergone the E-valve percutaneous mitral clip will have a mitral valve that actually does not move in the center and looks like a double orifice. However, that's not what our patient had. Our patient actually has a congenital double orifice mitral valve, which is a very rare malformation, and there are two mitral orifices. Most people will have actually mitral stenosis, and the way to calculate the area is to take individual areas and add them up. And if the total shows that there is mild, moderate, or severe stenosis, accordingly your management is impacted. Here, let's take a second look at that. And they're here in the apical two-chamber view. I like to show it because it looks like a seagull flapping his wings, because you can see there are two parts to the mitral valve, besides the double orifices seen here. Now, as you've noticed, this patient doesn't have significant mitral regurgitation. Just for your information, there can be two different types in terms of the development, either due to reduplication of the orifice or because of a fibrous ridge. But regardless, your reason to do a TEE is only if you get a poor echo, which wasn't the case here, or if you need clear definition of anatomical abnormality, such as the leaflets, the subchordal apparatus, or papillary muscles. On a 3D echo, we get more depth, but we pretty much see this almost similar to a good two-dimensional transthoracic echo. It's again important to know the company it keeps, and it's important to look for a VSD, associated ASD, Epstein's anomaly, tetralogy of Fallot, or left heart obstructive lesions. This valve can be normal, like in this lady, or could be stenotic or regurgitant. Now, isolated double orifice mitral valve is very rare, and a normal functional is even rarer. So this lady has a very rare condition and a rare presentation. Now, what would you say for her? Should she go ahead with a pregnancy, labor, and delivery, or should she not? A show of hands for those who will ask her to proceed. Again, no one wants her to get pregnant and proceed, but I beg to differ. She's functionally normal. It's working well, even though it's congenitally abnormal, and this lady can safely proceed with her pregnancy. And finally, I conclude, in the interest of time, with this case where a complete study is essential. This is a 39-year-old lady who's had aortic valve replacement for a congenital aortic regurgitation and came back feeling more dyspneic. We can see here on a 3D TEE that her aortic valve, the mechanical prosthesis, has a lot of pannus formation. But then when we went on to do the study, we noticed this unwanted mass bobbing in and out. Further evaluation showed there were many of them. Two of them you can see in this view. These are not thrombi. These are actually recurrence of a left atrial myxoma. We went back to her medical records, operation note, and saw that several years ago, she'd also had a left atrial myxoma removed at the time of aortic valve replacement. Hence, there's an importance for a complete study and access to old medical records. I shall conclude here by saying that all these modalities are helping us, but I see what the mind knows. So as we ride the wave of new technology, we need to see the patient in completion, starting from a good history, physical exam, use our clinical judgment, and the aid. I thank you for your attention, and I shall say the Philippines is so beautiful that it challenges the beauty of Hawaii by leaps and bounds. Thank you.